Okay, so I think it's a good time to get started. Welcome everybody to our session today. Hopefully you're here for the Guiding Principles of the Mental Health Act session, which Barbara Swann has kindly agreed to deliver for us today. So just some very quick housekeeping for you. If somebody could click on admit just while oh, it's okay, I've sorted it. Just some quick housekeeping. If you can keep your camera off whilst Barbara's presenting and mic's muted. If you've got any questions or comments, if you'd like to pop those into the chat, and we will be covering those when we get to the end of the session. There will be time for discussion and for questions. The session is being recorded and there will be a copy sent out to everybody who joins today. So Barbara's kindly agreed to share the presentation. In terms of live captions, I've put some details into the chat, how you can turn on your live captions if you need those. And I think we're probably ready to go. So I'm going to hand over to Barbara. Barbara is currently employed as an AMP with Northumberland County Council and is an associate lecturer at Northumbria University. So over to you. Thanks, Barbara.
Hello everyone, welcome to this session. As Denise says, I'm an AMP with Northumberland, and I also work at Northumbria University, mainly on the AMP programme. So this session is really about the guiding principles of the Mental Health Act, and it is really going back to some of the fundamentals, I guess, of our practice in mental health. And whilst I was preparing for it, I kind of really thought about my own practice and how important it is to go back sometimes to these fundamentals that perhaps can sometimes get forgotten when we get so embroiled in our own practice. So I'll just start the session. So the objectives really are, as I've said, is to really go over the guiding principles of the Mental Health Act and how important they are, and also what they really mean. So what they really mean in law and in practice, and how we can implement them into our social work, mental health practice. At the end of the session, I'll just go through a few summary points which I've made on my reflections really about the Mental Health Act principles. And I'm really hoping that at the end of the session, there'll be an opportunity for people to share their own experiences of using the principles in their own practice, because I think there's a lot to be learned from other people's experiences and how they can put them into their own practice. And obviously any questions at the end as well. So the principles of the Mental Health Act, where do we find them? So the guiding principles are in the Code of Practice, 2015 edition, and they're right at the front with the Chapter 1 of the Mental Health Act. So they're not in the statute, like the Mental Capacity Act. The principles are in the Mental Capacity Act. They are in the statutory guidance, but we still need to follow them because it's the law. And the guidance is really important for local authorities. We're expected to consider the guiding principles whenever we make decisions about people and their care, support or treatment. And they're expected to be followed, the principles, in all services that detain patients. It's really important because it provides professionals the support to allow their practice to involve people in their own care and treatment. And obviously it gives people who are perhaps detained or in some way being assessed or subject to the Mental Health Act, those protections and safeguards for people in mental health services. And this is a quote from the code, which I think does draw attention to some of the fundamentals of the Code of Practice, but also the guiding principles. So here it's about care and treatment should always be a means to promote recovery. So that's really important in terms of people's treatment. It's about recovery, be of the shortest duration necessary, be the least restrictive option, and keep the patient and other people safe. So that's really drawing attention to some of the rights that people have, which are underpinned with the guiding principles and the code of practice. Another fundamental part of the principles and the code is co-production, so making sure that people that have that lived experience have been involved in the development of the code of practice and its ongoing implementation. And it really does matter that those with lived experience are listened to and that their voices are heard, and those voices are put into the principles and the code. And again, this is about making sure that people know their rights, they have access to the code, and they're able to access the code if they need it and know about their rights and how they work for that particular person. And also about carers as well. So people with, as well as lived experience, their carers and family members can access the code. There is an easy read version of the code, which I've included as a link here that you might be interested in. So just here to bring it into perspective, some valuation of the code and the principles. So the CQC completed a report in 2019 looking at how well the code of practice was effectively implemented, and there's a link here for that report. Some of the findings in particular with regard to the principles were really about, so there's quite critical here of how the principles were being implemented, and there was a comments here about how there was a lack of understanding about how to promote and apply the guiding principles from the code, and there was a lack of support for staff to enable workers to have those meaningful and productive conversations with people about their own goals and their own recovery. So how enabling staff to work with the code, which would enable them to work with people to work towards their own recovery. And explicitly and specifically, there was a mention of IMHAs, so independent mental health advocates, which obviously are an important safeguard for people. And there were some difficulties there for people accessing an advocate. Overall, the CQC recommended promoting the use of the guiding principles to improve practice and enable meaningful engagement with families and carers. The guiding principles need to be recognised as a support tool for human rights-based approaches by staff and services. And I think that really kind of underpins the importance of the human rights perspective here and how important that is for people who are subject to mental health services in some way, who are working in the sector, and how their human rights need to be protected. So I'm just going to go on to talk about the actual principles and what they mean, and some examples of how they can be or should be applied in practice. So these are the guiding principles that are in the Code of Practice 2015. So they start with least restrictive and maximise independence, empowerment and involvement, respect and dignity, purpose and effectiveness, efficiency and equity. And there's just a note here about them all being of equal importance, but perhaps in some contexts some are more relevant than others. I think my point here would be that I often, and I think most of us often hear the principle of least restrictive being mentioned, and some of the others aren't mentioned as frequently in practice. So that's often quoted, the least restrictive option, when we're looking at alternatives perhaps to detention and admission in hospital. But I think our attention to some of the other principles is perhaps often lacking, and sometimes they're a bit more neglected. But of course, they're all of equal importance in the code. So I'm just going to go through the principles and what they mean. So the least restrictive option and maximise independence means that where it's possible to treat a patient safely and lawfully without detaining them about under the Act, the patient should not be detained. Wherever possible, a patient's independence should be encouraged and supported with a focus on promoting recovery wherever possible. So this is a really important area of practice. So this is what it means, where it's possible not to detain a person, then of course they shouldn't be. I mean, the focus here is often or should be on early intervention and preventative services. And if the person is detained, it should be for the least amount of time necessary and in the least restrictive way, and as close to families and carers as possible. And I think that's really important at the moment, specifically in particular around people being moved around the country, because there's such a lack of beds. You often find that people are separated their families for long periods of time. They have to travel to the other part of the country to access a bed. And I think we need to consider that in terms of this principle, that it's working against that person's independence. And also, it really does mean that that person will have much less contact with their family and carers. It'll be much more difficult. And in terms of restrictions, you know, even though somebody's detained in hospital, which of course is very restrictive, there's often other restrictions included in the care and treatment when somebody's detained. So the wards, I'm sure, need to think about how they can reduce those number of restrictions. So people may not have access to personal belongings, they may not have access to phones. You know, how easily is it to access family members either on the phone or some other way through a video call? So it's just about thinking about, even though somebody might be detained, which would appear to be the most restrictive option, within that there's restrictions that need to be considered and to see whether they're actually necessary for that person's safety or for the protection of others. So that's when we're talking about restrictions being the minimal amount necessary to provide that care. And the last point here about blanket restrictions, so affecting everyone, should be avoided and never for the convenience of the provider. So an example of that could be, you know, the blanket restrictions that were brought in often in care homes for older people during COVID, the do not attempt resuscitation orders, so that they kind of brought those in for everyone, every older person, when really that was against both the principles and the law of the Mental Health Act and the Mental Capacity Act. Okay, so we'll go on to the second couple of principles here, which are empowerment and involvement. What we will find is, I'm sure what you do find is, the principles overlap, so they all work together in lots of ways. You know, there's a bit of overlap between them, and there's a kind of a theme amongst them all as well, which is really about patient rights. Empowerment involvement, patients should be fully involved in decisions about care, support and treatment. The views of families, carers and others, if appropriate, should be fully considered when taking decisions. Where decisions are taken which are contradictory to views expressed, professionals should explain the reasons for this. So in practice, this means that people, you know, it is what it says. People should be involved in decisions about their own care and treatment wherever possible. And to enable that, obviously, reasonable adjustments should be made to ensure the person can participate. For example, information provided in an easily accessible format. I think, you know, what we need to consider here is that the Mental Health Act is applicable to anybody of any age as well. So those reasonable adjustments need to be considered for that individual. But if we think about that in some ways in terms of client groups, what reasonable adjustments would we make for a young person, perhaps for somebody with dementia, for somebody who's physically disabled or has a learning disability? So we need to think creatively about how we can involve that person in as much of their caring decisions as possible. One way of doing that, but also in their own right, would be to involve carers and family members and consider their views, and also access to an IMHA. So if you're detained under the Mental Health Act, you have a right to an IMHA, and that should be facilitated. So to an advocate who can represent your voice and needs and wishes, particularly if it's difficult for you to share those. The code as well, and the principles here do talk about making sure we're aware of a person's views, wishes and feelings, both in the past and the present. So the past might well tell us more about what the person's not able to tell you at the moment. And it does talk about advanced statements to inform future care and treatment decisions. So it'd be interesting to see how many people have used that. So the code does talk about people making statements about what their preferences are. And of course, that's a good way of explaining and putting your views across, especially if when you're unwell at some point that you might not be able to do yourself. And we need to be able to record, so we need to know what those wishes and views are of the person that we're working with. And we should only really deviate if there's good reason to do so, and explain that to the person why we are deviating from them and recording that. And I was just thinking of an example of this myself recently. So I went to a meeting which was for a man who had been in hospital nearly 12 months, detained under the Act. And so I'd been allocated his case as a social worker, and I was invited to a progress meeting. And it was a sort of a hybrid meeting. So some people were on Teams and some people were on the ward. I chose to go to the ward because I thought that would help facilitate communication easier with the person. I could see, I found this out afterwards actually, but 50 people had been invited to this meeting. And when I asked at the end about involving the person, because the person who had been detained wasn't involved in the meeting, I was told that they hadn't been invited. It wasn't a meeting for them. So we have to think about really how are we involving people in decisions about their care and treatment and meetings when they're actually not even invited to the meeting. And there was nobody there specifically representing their particular views and wishes. Okay, we'll go on to the next one. So as I say, a lot of these, the principles, the themes travel throughout all of the different principles and the themes. There is, a continuity in the themes between them. So respect and dignity, patients, their families and carers should be treated with respect and dignity and listened to by professionals. So I guess in my previous example, I don't really think there was demonstrated a whole lot of respect for this person because he wasn't invited to his own meeting about his own care and treatment. So people and the carers should be treated with dignity and respect, and we need to recognise the diverse needs of people. So whatever their values are, whatever the circumstances are of the patient, including the age, disability, gender, etc. So we need to put that person centre stage, think about what that person's needs are, what's important to them, and work with that person and their circumstances. Whoops, go back a bit. So the next one is purpose and effectiveness. Decisions about care and treatment should be appropriate to the patient with clear therapeutic aims, promote recovery, and should be performed to current national guidelines and/or current available best practice guidelines. So with this principle, I think what struck me, to be honest, was thinking about it more, was that it talks a lot about therapeutic treatments and options for people which promote their own recovery. So we need, as practitioners, to be aware of care, support and treatment options available and be up to date with best practice guidance. But we also obviously need to be aware of what that individual thinks would be therapeutic for them and what their preferences would be. And it does talk a lot, although we tend to focus quite often, I think, on inpatient settings on medication and pharmacological options. It's much wider than that, the therapeutic treatments on offer. And here the code and the principle does draw a lot from what you would consider sort of psychosocial treatments and interventions. So it does talk about supporting relationships, housing, opportunities for meaningful engagement and employment, which promote somebody's recovery. So, there's a lot in there about social perspectives and social work values and much more than medication and what that offers. So it does take that much broader focus of medical treatment and brings in lots of other therapeutic treatments as well. And of course the focus is on recovery, and again we're talking about getting that person and ending it out as hospital as quickly as possible in the least restrictive way, but also making sure that they've got that focus on recovery in the community. Oops. So the last principles are called efficiency and equity. So this really is about providers, commissioners and other relevant organisations working together, ensuring that we provide a good quality service for people, and it's of equal priority to physical health care. And again, all relevant services should work together to facilitate timely, safe and supportive discharge from hospital. So if anything from this, I would take the view that really we need to be able to foster and have good, effective working relationships with the people that are subject in some way, the people with a lived experience or are subject to parts of Mental Health Act or perhaps have been about to be. So it's getting good relationships with the people with lived experience and their families and carers, but also with other agencies. So working well with other professionals so that we can implement a service, implement a plan that's going to work for that particular person. And to be able to do that, we need to have sufficient training. We need to have the knowledge and the skills about the Act and also other therapeutic options and treatments that are available. And also, that equity with physical health. I think, we can often draw parallels with some differences there. So in my niece actually works at A&E in Scotland, and she often, she's a really good nurse, and I'm sure she works really hard, but she often makes comments about how people who perhaps have self-harmed or people with mental health problems turn up at A&E, and I see there's always a negative connotation to that. And I think that's because people often assume that somebody with a mental health problem isn't of an equal status to somebody with perhaps a physical health problem. So I think there's that lack of equity, and also perhaps the stigma attached to mental health problems that needs to be challenged. So this next few slides are just about some of the key themes that I've picked up through the principles and what they're really trying to achieve. So for patients and for carers, where possible, detention should be avoided. And if you are detained, it should be for the least amount of time as possible, in the least restrictive way, and as close to your home, families and carers as possible, preferably in your local area. People and their carers should be involved throughout in the decision making about their own care and treatment, and consider any support required and adjustments made to ensure their involvement is meaningful, and including access to an MHA, but not just exclusively that. So thinking about how we can involve people in their own decisions and care and treatment as much as possible. And people should be able to access therapeutic treatments, be really given a choice about what's going to work for them based on their own needs and wishes, and people need to know about their rights and how to access them. And in terms of workers, what's important for us to remember as professionals working under the Act, we need to be aware of the principles, what they mean and how to put them into practice. And that might be, that we continue to go over those principles, discuss, hopefully like we will do today, about good examples of how we can put those principles into practice. And I think it can really give us a good framework for how we work, so it sort of sets the rules and standards for our work and engagement with people. And it's really up to us as well to be up to date with current therapeutic care and treatment of options, asking what is available for that person, perhaps other than medication, other than pharmacological options. And we need to work together with our partner agencies, so all of those agencies that are involved in looking after that person, providing the treatment, and also the people with lived experience and their carers. In the final few slides, I've got some references and links at the end, but this is just really about where we're heading and putting this into some context as well, perhaps for our future practice. So I'm sure we're aware that there's been the independent review of the Mental Health Act back in 2018, and as the title suggests, this was about increasing choice for people and reducing compulsion. And the review recommended that the key guiding principles were actually put directly into the Act, so that they would be front and centre for people to follow. And these were very much rights-based, and promoted people's choice, and it was about restoring dignity to the person and the mental health system. And these principles were choice and autonomy, least restriction, therapeutic benefit, and treating the person as an individual. Unfortunately, the draft bill didn't put these into the actual Act, and we've sort of gone through a process of having pre-legislative scrutiny and having a report published by the Health Select Committee, but sort of reached a dead end at the moment. And I guess we're waiting to hear from the new government, once we've had the general election, where we're heading in terms of reform of the Mental Health Act. But there's been quite a lot of debate about where the principles should sit, whether that would continue to be in the guidance or in the Act. So it might be interesting to hear your thoughts about that as well. But I think, the principles are rights-based, and although they might vary in terms of what they actually are and how they're described, they're basically about making sure that we work in a person-centered way and we take into account the person themselves, their needs and wishes. So I'll just show you the end there for some resources and references that you can refer to in your own time. So thank you. And if we've got some comments or any questions.
That's brilliant. Thank you so much, Barbara. There's so much information in there. And just for anybody who did join us a little bit later, just to say the presentation will be shared, so you'll have access to all those links. But we're going to open it out now for discussion and any questions. That there aren't any in the chat at the moment. There's some helpful links that have been shared by Tony. But in terms of questions, did anybody want to ask anything?
I'll talk. I'm not. It's not a question. It's a observation. I'm sorry, Barbara. I always end up sounding like the grumpy amp. Okay. My name's Tony. I'm an amp.
Hi, Tony.
I'm a great big fan of the code of practice. Okay, but nobody except us reads it. No one holds commissioners to account for not applying it. I've had big cheese commissioners come over to see to me, and I put it in front of them and say, "Have you ever read that?" No. Nurses don't read it. Commissioners don't read it. It's only us amps that read it. And the two examples I always give is around Section 140 and around, I work in an area where they send loads of people out of area, particularly children. And it says somewhere in the code, 1485, when the patient's care informs the commissioner of difficulties in visiting, then they should, not would, could, it should help them to visit. I mean, I've literally been to your part of the world to see people that are detained and met families who've stayed in car parks the night before. You know, so I'm a big fan of the code. Part of it is out of date, particularly around chapter 16. But, you know, no one, the CQC don't look at stuff that's free hospital, although they are responsible for it. They tend to just stick to inpatient stuff when they do the reports. And, you know, I would have the principles in the legislation if I was in charge of changing it. And there you go. Little speech.
Oh, thank you, Tony. Yeah, I mean, I agree with you, and I think that's probably why I wanted to sort of do this on the principles. And I think you're right. You know, we do look at the principles much more, or the code of practice much more than perhaps other professionals do. But I suppose in terms of doing this session and in preparation for it, I think, you know, the principles are the simple part, surely, of the whole code. And I'm wondering, you know, if we take it down to the basics, yes, there's other areas of the code that people don't follow, but if we take it down to the fundamental principles, I mean, we could argue, of course, that they should be in the Act, but they're not at the moment. So the principles could really help. I suppose the idea was really to help empower workers. You know, if we're aware of them, we can question our colleagues and challenge them on a day-to-day basis. And I suppose a lot of it as well was about like the grassroots work, you know, in every intervention we have, if we're mindful of the principles, then it'll help shape how we practice.
I mean, the other example is the conveying of patients. You know,
Yes.
following a mental health act assessment, it's there. It tells us how it should be done, but we're dependent on what tends to be legacy contracts. And the NHS, back to your point about your niece, I think.
Yes.
The ambulance service where I am don't want to be picking up mental health patients. They don't prioritise it. And the first question they ask when you ring them is the person likely to be dangerous? It's the first question they ask. I say, no, unhappy, not dangerous. Could you send an ambulance, please? But you know, the ICBs as they are now aren't held to account for their commissioning arrangements.
So do you think there's ways that we could challenge that further as an AMP group?
I think AMPs are very good at making noise. I make a lot of noise. I've been to ICB things. I've done all sorts of things, but ultimately it falls to our big bosses to hold them to account in the meetings that they go to. But in my experience, our big bosses, AMPs and mental health aren't part of it. Adult social care, we're a little bit over there. Do we belong to the NHS? Do we belong, in it? And they have other priorities. And the NHS is a big, horrible, nasty partner sometimes.
Yeah, I think we can feel swamped by them. Has anybody got any comments or observations about their own practice in terms of implementing the principles? And it's got some good examples about how we could implement them?
Amy, yeah, would you like to? And feel free to put your camera on, by the way, if you're asking a question or you're joining the chat.
Yeah, I wanted to reflect how helpful it was to review the principles, because I'm a social worker in an general adolescent inpatient unit, and I think we are very much following a medical model at this point still. And part of that is continuously, my role as a social worker within the MDT is continually bringing it back to the voice of the young person, to the voice of the person who's been detained, and how we can incorporate their views into their care and treatment planning, and continually coming back to that, but coming up against that medical model, which is a constant theme in every single discussion we have about how we can change things. And it's all very much, okay, well, you go and deal with those bits, you go and get the people's views, and then just let us know when you've got that. And it's not what I was reflecting on, is that the lack of buy-in from the consultants and the doctors who are involved in those mental health act assessments. And I think it's really helpful to really, and like you said at the start, bring it back to the basics around the principles and how we can bring that into every single conversation, and the language we're using within reviews and within our care and treatment reviews, to help promote that and really take it back to what's really important in the person's rights and their involvement in their treatment plan. So I just want to say thank you, because it's a really helpful space to be able to think about, think about these things.
Yeah, thanks, Amy. I think what you're saying is very much how I sort of feel about it. In preparation for this, as I say, I often hear list restrictive mentioned nearly all the time, but patient involvement and empowerment are hardly ever here. And it's not just for the social workers or the AMPs to talk about. It is, we are, as you say, we've all got to have that. They might not buy into it, but they're also obliged to follow it as much as anyone else. Although you might have these medical models and treatments that are available for people, but a lot of the Act, and well, not so much the Act, but a lot of the the code is about empowering people, and that's where it's heading. We are hopefully heading to more of an empowering piece. Oh, well, I suppose that's the optimistic side, to think that we can empower. There's the law there that supports us to empower people, and reminding people of those principles. They'll get sick of it, and eventually they will end up, using the same language, or using the language of the code of practice, like we all should be, really, shouldn't we?
Barbara, it's Denise. I'm guessing you probably can't see hands raised because you're still sharing your screen, so I don't know if you want to take your screen down, but it was just a quick question from me, actually, and I think Roseanne's going to come in. But in terms of, you made reference to difficulties around the MHA and access to MHA, and have you got a sense in terms of those difficulties? Is it that the service isn't available, there's not enough provision, or is it a mixture of things that perhaps people aren't actually being made aware of their rights, they're not being given the option, and the referrals aren't being made? And second to that, then, do you think it will make a difference if they implement the request, as was in the mental health draft bill, that it becomes an opt-out, that MHA would be opt-out rather than opt-in?
Yeah, I mean, I think it's probably just, I suppose I can only, in terms of my own experience, I think that people are often referred for IMHAs, like the wards that we work into, people aren't nearly always automatically referred in, but I'm not quite sure. It's rare that, to be honest, these days, that I even see an IMHA at a meeting that you would have expected them to be at. And the reference to that example I gave before, that the man's progress meeting, I was told that he had an IMHA, but they hadn't come. And then when I looked, I saw that he didn't have an IMHA. He had an IMHA, but his case had been closed down, and they hadn't. I don't know why, but an IMHA really needs to be involved in that. So I think it does get lost a little bit, and I think IMHAs are often a little bit on the periphery. It's not seen as so important. So I think it's really crucial to people's rights. So I think if they change the law and do make it so that you have to opt out, I think that'll be much better. And also, recognizing that IMHAs will have hopefully that diverse experience and be from diverse backgrounds to meet the needs of people, the real breadth of needs of people that come into services. So I think it's a big issue. It's all very well to say you've got access to an IMHA, but it has to actually mean that, doesn't it? It has to actually happen in practice, that people do have access to an IMHA and that him is involved. It's not just something that's been written down on a form somewhere.
Absolutely. I think just looking at Amy's point in the chat, the fact that actually some of the IMHAs are carrying caseloads, or they're working with people up to 80 people at a time, in which case actually then it's also about what actual input can that, it has to be, realistic, it has to be achievable what they're going to be doing, because with a caseload like that, really, are they going to be able to build a relationship and be able to fully take on the role of an advocate? And I think in terms of where those referrals aren't being made, I think it does come back to Tony's point again around, commissioners' responsibility in terms of, that they're setting up the contracts for these provisions. Actually, who's monitoring that to see, well, has there been a change in numbers? Did the pandemic impact on practice in terms of involving people beyond the ward in the lives of individuals? And what are they going to do to kind of push that again? Does training need to be rolled out to remind people of the need to involve IMHAs and to promote the service? So yeah, thanks Barbara. I'll hand over to Roseanne, who has a question or a comment.
Hi everyone. Thanks Denise, and thank you for the presentation, Barbara. I'm just going to briefly introduce myself for those of you I haven't met before. My name's Roseanne and I sit in BASWA's policy and research team. And one of the reasons I have an interest in the Mental Health Act is because the policy and research team cover those issues that relate to social work, which aren't, which cross devolved jurisdictions. So in this case, we know the Mental Health Act covers England and Wales. So then I have a role in coordinating what we put in to either the UK government or the Westminster Parliament on these issues. And I just wanted to follow up one of Barbara's closing slides, which was around legislation and the fact that we've got an upcoming general election. I think just to provide you a little bit of context with where we think we are. So some of what I'm going to say is going to be what we know, and some of it is going to be a little bit of speculation based on the fact that I've been working in health and social care policy for well over a decade. And I've seen governments come and go in both the UK and Wales. So with the election coming up on 4th of July, if we look at the current polling, we're fairly certain we're going to get a Labour government at UK level. What we know so far about the prospect of a mental health bill is that Wes Streeting, who is the current Shadow Health and Secretary, Health and Social Care spokesperson, committed last November to having a draft mental health bill introduced in the first King's Speech of any incoming Labour government. If they follow through on that, it means we would expect them to move fairly quickly, because we're going to have a King's Speech probably by the middle of July. This is the bit where I move slightly, I think, to speculation. But I think the fact that they would, if they do go ahead with that and put it in the King's Speech as early as planned, I think it means that they will largely be going with the draft mental health bill that went to the pre-legislative scrutiny committee in 2022 and into 2023. I say that because if you go straight to the King's Speech, it doesn't look like there would be space for a large round of consultation on a new white paper on what should be done. So I think the bones would largely be the same as that which we have already seen scrutinised and discussed. They may well take on some of the recommendations that came out of that joint scrutiny committee. We won't know until we see the draft legislation. Once we have draft legislation before Parliament, then we, and I'm using we as a kind of royal we of BASWA, we would be looking at that to see if there would be specific amendments that we would want laid. And at that point, through Denise, I will probably be coming back to talk to you about what it is specifically that we might like to see. And the trick with legislation, because of the way in which it is drafted, is that these do have to be quite specific things that we're looking at. So I just wanted to kind of bring you up to speed on what we think might be happening if we have a Labour government. And that is, I think we would expect something to move quite quickly. For those of you who have that sort of crossover interest, we're not currently expecting a similar speed of movement on mental capacity. We've heard nothing on from Labour on mental capacity at all so far. And as we know, the last government also iced the introduction of the new mental capacity code of practice and the introduction of the liberty protection safeguards. So we have a position from a potential Labour government on the mental health bill. We don't know what might happen yet on the mental capacity side. I hope that's been helpful, but if you do have a question for me, then you know, without wishing to step on Barbara's toes because it's her presentation and session, then you know, I'm willing to follow that.
That's great. Thanks, Roseanne. And maybe Roseanne, if you wanted to put your contact details into the chat if anybody has any questions post this discussion. So just going to open it out again to everybody. Any feedback, any examples of good practice, any kind of areas you wanted to cover and just discuss to find out, perhaps even because the breadth of who's in here, who's in the room today, you might want to find out actually what's happening in other areas. What's happening in your area might not be, you know, reflective of the entire country. Sometimes we can feel that our reality is the only reality in terms of particularly when we're looking at service provision. So just opening it out, I think we've got a couple of comments have just popped up. No, so we've got a link in there from Tony. But yeah, anything anybody wants to come in on? No? Silenced. I think it's because it's lunchtime, isn't it? People thinking I need my sugar fix. I'm just going to pop a link in to the chat for an evaluation form. It's a really brief form. If you don't feel any other questions on it, the one that we really want to hear about is future sessions. Is there anything you'd like us to cover? Barbara's been very kind in coming along to provide this session today, and we will, you know, reach out to people within our groups, within our networks to provide sessions if we don't have that kind of resource in-house. So if there's something that you want to see related to mental health and we haven't covered it before, or even if we have and you want a refresher around it, then pop it into the chat and we'll do our best to try and accommodate that in our future lunchtime sessions. Barbara, was there anything you kind of wanted to? Oh, yeah, so just a comment in there from Roseanne. Barbara, was there anything you wanted to add?
Well, I suppose it is an exciting time in lots of ways, isn't it, for mental health law and for the policy changes and changes in the statute that we anticipate. So it's good to hear that if the Labour government do get in, which looks like they will, that they're going to, you know, really grasp Mental Health Act and do something about it. I think it would be a bit disappointing though if they didn't make any amendments to the actual bill, given what we've just been saying about the principles and having those in the actual act and on the statute. But I suppose for me, this session was really just about bringing us back to focus on what we can do. You know, it doesn't necessarily mean that we have to wait for these changes, although of course they would be really welcome if they came in. You know, there's legislation there, there's guidance there that we can certainly work with and challenge people about if they aren't adhering to those really important guiding principles.
Exactly, I think that's really important, Barbara, isn't it? That, you know, we can wait there's lots of areas of social work where we're waiting for new initiatives, we're waiting for new guidance, etc. But that doesn't mean that we have to stand still in the day-to-day practice. Not that I think anybody in this room would.
No.
The fact that they're here today wanting to cover this kind of says quite a lot, really, in terms of people's passion to kind of promote that autonomy, promote people's rights, etc. So yeah. I'd like to say a huge thank you, Barbara, for giving you time to do this. It was really informative, and we will be sharing the presentation afterwards. We'll get it out via email to you all. And a huge thank you to everybody giving up your lunch break to come along. Thank you. I'm just going to have we've got a final comment in there from Susan, and it's a thanks. Yeah, thanks, Barbara. And also Roseanne for your feedback. That was really helpful too in terms of the wider walk of Basra. So enjoy the rest of your working day, everybody. And yeah, hopefully we'll see you back at another one of our lunchtime sessions. So take care.
Lovely. Thank you very much.
Thanks, everybody.
Bye,
Bye-bye.
everyone.